Hello, I'm Kerry from the Patient Public Involvement Team at the Royal College of Obstetricians and Gynecologists, the RCOG. Thank you for joining us for our information webinar on Group B Streptococcus in pregnancy and newborn babies. Throughout this webinar, we'll be referring to Group B Streptococcus as Group B Strep or GBS. So I'm joined by three people who have a wealth of knowledge around all things Group B Strep related. Jane Plumb, founder and CEO of Group B Strep Support, Philippa Cox, consultant midwife, and Dr. Ugwumadu, who's a consultant obstetrician. So I'm just going to get you all to introduce yourselves and tell us a little bit about what you do. So Jane, we'll start with you.
Well, I'm Jane Plumb. I'm Chief Exec and founder of the charity Group B Strep Support. My husband and I founded the charity in 1996 after our son sadly died from Group B Strep infection. And the objective then and is now is to stop these infections in babies. Outside of the charity, I'm co-vice chair of the RCOG's Women's Network. I'm also a co-applicant on a number of Group B Strep clinical trials, and I'm a committee member of the guideline, that's the NICE guideline update for neonatal infection, and I'm also a member of the Pregnancy and Baby Charities Network, and I'm a mum of two gorgeous children.
Thank you, Jane. Philippa?
Hello, I'm Philippa Cox and I'm a consultant midwife at Hamilton University Hospital, which is in North East London. I've been a consultant midwife for 10 years, but a midwife for a lot longer, about 30 years. And I'm also on the medical advisory panel for Group B Strep Support Group and have been on the panel for about 10 years. I get involved in supporting women with their choices during their pregnancy and their birth, and I get a lot of queries around Group B Strep, and that's partly why I sort of joined the medical advisory panel to sort of get my knowledge increased, and so I can pass on the information to the women I support in their pregnancy. I'm not as busy as Jane, but I do have two children of my own who are grown up now.
So thanks, Philippa.
So I'm an obstetrician and gynecologist, and also clinical director for women's services at St. George's Hospital in South London. I did a doctorate in the role of subclinical infections in pregnancy, and that's going back nearly 20 years now. Group B Strep happened to be one of those subclinical infections, and that's part of my interest in the subject. I'm particularly interested in what Group B Strep does in the mid-trimester, long before babies mature to the point where they go into labor, which is where the focus currently is. I've also been editor of infectious diseases in obstetrics and gynecology, which is one of the international journals in infections. I've been editor for 10 years of the college journal, the BJOG, and also sections editor for the section on Global Library of Women's Health. I've continued to maintain my interest, both clinical and research, in the area of infection in pregnancy.
Fantastic. Well, it sounds like between the three of you, we can answer every question on Group B Strep. So let's start with the obvious question. Austin, could you tell us what is Group B Strep and how is it found in women?
Okay, so Group B Strep is actually a naturally occurring bacteria, which is more commonly found in the lower rectum and the anal canal. It's present roughly in about 10 to 40% of the population. Men carry it as well, but luckily they don't have to have babies, so it's not a problem in that population. Medically, we refer to it as a gram-positive coccus. You know, it has a particular purple stain if you were to examine it under the microscope. How is it found? The main reservoir is in the lower rectum, but under certain conditions, you can find it in the vagina. And in extreme cases, in heavily colonized women, you may find it in the urinary tract. The distribution will depend on which ethnic group you're looking at. So I did say the prevalence is roughly 10 to 40%. In women of African ancestry, it's closer to 35 to 40%. In women from the South Asian continent, you'll be looking nearer 10 to 15%.
And do we know why that is?
That's not very well understood. That is just the distribution that has been documented and reported in almost every series you look at.
And so just thinking of the woman coming along to a clinic, how would she find out if she has Group B Strep? Right.
Most women in the UK will find out that they've got Group B Strep as a matter of accident. So either because they've been tested opportunistically whilst we're looking for other things, or women, when they start pregnancy, will have a urine culture that's a routine. And every now and again, you pick up Group B Strep colonizing the urinary tract. Women who come in either complaining of suspicion that they've ruptured their membranes or unusual discharge or have had some bleed will almost inevitably have a vaginal swab, and quite often Group B Strep colonization will be highlighted. I have to say at this point that our technique for sampling for Group B Strep is so poor that the women we pick it up on are the ones that are so heavily colonized that our best attempts to miss it fail, which is why we find it.
Okay. And so you're saying it's a swab, so that might be something a midwife could do, or an obstetrician, just thinking, or a GP.
Yeah, anyone could do a swab for Group B, including the woman herself. But certainly in the hospital setting, we tend to do high vaginal swab, which is actually what we shouldn't be doing. If you wanted to increase the yield and isolation of Group B Strep, what you need is a low vaginal swab swept over the perineum and then set around the opening of the back passage. And if you miss out those steps, your yield and pickup will begin to degrade quite significantly.
And so we've heard a bit about what Group B Strep is. So what can it mean for a baby?
Well, for a baby, usually a baby won't be impacted by Group B Strep at all. Most of the babies who are born to women who are carrying Group B Strep in the lower vagina and the rectum won't have any adverse effects at all. About half of the babies born to women who are carrying the bacterium when they give birth will themselves carry Group B Strep. But again, your carriage doesn't cause any problems, so there's no real need to know about it. Sadly, that's not true with all babies, and the reason that Group B Strep is so important is because Group B Strep can cause really nasty infections, and most typically those infections are sepsis, pneumonia and meningitis, and quite often a combination of more than one of those. Most of the babies that develop a Group B Strep infection will have intravenous antibiotics given to them, and that will cure them. That they will then recover fully from their Group B Strep infection. But sadly, again, not all do. And some of these babies, these very sick babies, will die as a result of their infection. And some of the babies who recover will suffer long-term health issues. And roughly, on average in the UK, about 2 babies every day will develop a Group B Strep infection. 1 baby a week will die as a result of their Group B Strep infection, and one of the survivors of their Group B Strep infection will have long-term health issues as a result, which is why it's so important to do what we can to prevent these infections. Group B Strep infections in babies are usually described as being of early onset or late onset. So the early onset infections show within the first 6 days of life, and usually within the first 24 hours. And those are the infections that so often can be prevented. The late onset Group B Strep infections occur after that first week, and are very rare indeed after 3 months of age. And at the moment, we don't have any good prevention for those. One day there will be a vaccine, and hopefully that day is getting closer and closer. But at the moment, all we can do is to make sure that parents are aware of what signs to look for, so that urgent treatment can happen.
And what are those signs then that parents should be looking for in a new baby?
Basically, a baby being poorly. So if a baby is unwell, if their breathing isn't right, if they're making grunting noises and having difficulty catching their breath, I think probably Philippa and Austin would be better at describing signs. Although we do have in the resources a poster which actually we regularly send to women, and they stick it on their fridge to be aware of what signs to look for in a newborn baby.
Yeah, so as you say, sometimes the baby's, breathing doesn't sound right. We sort of use terms like grunting or just really noisy breathing, which you wouldn't sort of expect in a newborn baby. Sometimes they're just very floppy, whereas you'd expect babies, arms and legs to be moving around. They could just be crying, and again, I know babies cry, but they could be sort of more pitched crying. They may not be interested in feeding, and we want all newborn babies to be feeding regularly. So if they're not feeding and they're sleeping for very long periods, that's not a baby we'd be happy about. There are observations that the midwifery team or neonatal team may undertake, and there may be changes in those. So, for instance, we would be monitoring the baby's temperature. We'd be monitoring the baby's breathing, but also the rate of the breathing and also the heart rate. So there could be changes in those.
And Jane, what are some of the risk factors for a baby developing their GBS infection?
For a newborn developing the early onset infections, the key risk factor is mum carrying the bacteria. But there are also other risk factors. For example, if a previous baby has developed a Group B Strep infection, then it means that any subsequent babies are at raised risk. If Group B Strep's been detected in any way, shape or form during the current pregnancy, be it from a urine sample or from a vaginal or rectal swab. If baby is born preterm, so before 37 completed weeks of pregnancy, then that's another risk factor or red flag for a baby developing a Group B Strep infection. Where the waters have gone a long time before the baby is born is another risk factor, as is mum having a fever during labour. So each of those situations means that a newborn baby is more likely to develop an early onset Group B Strep infection. And in terms of late onset Group B Strep infections, the key risk factors that we know at the moment are mum carrying Group B Strep during her pregnancy, and also the baby being born preterm is another important risk factor.
And so what can be done to lower those risks?
So if mum is known to carry Group B Strep, or she's previously had a baby with a Group B Strep infection, or is in term labour, then mum will be offered intravenous antibiotics. So antibiotics given through a vein, through a cannula, and at regular intervals, typically 4-hourly, until the baby is born. And those are given as soon as possible once labour starts, or the risk has been identified, for example, preterm labour, or the waters break at term. And typically the antibiotic that's given is penicillin. And that's not only because it's very effective against Group B Strep, it's also very safe. It's one of our most tried and tested antibiotics, and it's narrow spectrum, so it's less likely to cause negative impacts as the other broader spectrum antibiotics that might be given. And For some women are allergic to penicillin, and it'd be really important that those women make sure their health team know that, because there are alternatives that can be given. So typically either a cephalosporin or vancomycin are the antibiotics that are recommended for women allergic to penicillin. And that is, those antibiotics in labour are universally accepted as having a huge impact on reducing Group B Strep infections by up to 80–85% in the young baby.
And if a woman does miss that kind of 4-hour window, are there any certain implications?
The recommendation is those antibiotics should be given as soon as possible once labour starts. So there shouldn't be a waiting until you've got 4 hours before the baby is born. They should happen sooner rather than later. And if mum delivers before the 4 hours is up, then there are observations that the health team will do on the baby just to keep an eye on it and make sure that the baby isn't showing signs of infection.
And how do you identify that a woman has GBS and needs to be given antibiotics in labour? Is there anything that you do as healthcare professionals? Do some places put stickers on maternity notes and things like that?
Yeah, so, well, I was going to say, do you want to go?
Yeah, so, Jenny has very kindly covered some of it, but yes, so because we don't have universal screening in the UK, we're on opportunistic screening as it were. But once women have been recognized to carry the bacterium, then they get, in my institution at least, and in most of the institutions, and they put a sticker to identify. Yes. Yes.
Here's one we compared earlier.
Exactly. And that is exactly that version that we use in my hospital. So that highlights the risk. If I may just return to the antibiotic situation, the good news, one of the good news with penicillin is there are no reports of Group B Strep strains that are resistant to penicillin. So if a woman is not allergic to penicillin, penicillin is first choice, and you can be guaranteed that bacteria is dealt with by that penicillin. The problem is when they're allergic to penicillin. And I know that majority of trusts in the UK still have agents like clindamycin, erythromycin as alternatives. Now, as I understand the literature, resistant strains of Group B Strep to erythromycin is currently running at just under 10%. So there are situations where women are allergic to penicillin. The healthcare professionals have not actually requested for sensitivity studies when they took the sample. So as far as they're concerned, their guidelines say if allergic to penicillin, give clindamycin or give erythromycin. Now, you may be giving the erythromycin not realizing that it's not going to work half the time, or offering the woman clindamycin not realizing that at least 10% of Group B strain will be resistant to clindamycin. So my advice to clinicians will be, if you're in that setting and your guidelines still advocates clindamycin and or erythromycin, as you take the sample, you should be asking the lab to give you sensitivity studies if they isolate Group B Strep. Otherwise, you begin antibiotics, that would be totally ineffective.
Maybe suggest they update their guidelines.
Exactly. Yes. The RCOG guidance is 2 years old now. So
yeah, and in there, they should.
Can I just say something about how it might be detected and how women might get to find out? So, as Austin says, most women will probably find out through incidental testing. But I think when women are pregnant, they'll have a lot of tests, and I think it's very important for women to make sure they find out the results of those tests, so that if they are found to be GBS positive, and make sure that they put a sticker on their nose, or other health professionals are alerted to the fact that they have it, because your named may not be there with you at delivery, and we need to make sure that everybody's aware.
Yeah. So that's kind of if you have a UTI, you're in tract infection, following up on the results to
absolutely, because if GBS is found in the urine infection, for instance, then they'll need treatment during the pregnancy for that infection, as well as having the intravenous antibiotics during labour.
And I mean, Austin's right, most trusts use these stickers that we produce, but if a mum's hospital isn't using them, then they can get them from us.
Okay.
They can get them from us as well.
Okay. And Philippa, what are some of the options for a woman who has risk factors for her baby developing a GBS infection? Looking at where she can have her baby, what are some of the options available there?
Well, part of the answer to that question also depends on other aspects of the woman's pregnancy, because there may be complications in that pregnancy that require her to be in a certain area for delivery. Essentially, we would recommend anyone who has risk factors for Group B Strep or has been identified as Group B Strep positive in the pregnancy to have their baby in hospital. Where they have their baby in hospital will depend on other things that's going on in the pregnancy. So, Jane, for instance, talked about preterm labour, or where the waters have gone for a very long period of time. They may want to start labour, or that may be a delivery suite. But if the pregnancy is otherwise completely uncomplicated, then a birth centre is a good option. That would probably be in alongside birth centre, because there are some trusts that have freestanding birth centres, and really this lady would need to be in a hospital as neonatal support, which may not be available in a freestanding centre. Most trusts recommend hospital delivery, so home birth is usually advised, not against, really. So because of having the intravenous antibiotics mainly, and also if the baby requires observations for 12 hours, it's something we can do at home.
And in terms of having a vaginal birth or a caesarean or being induced, are there any differences to treatment within those different births?
Well, if they're having a vaginal birth, then the intravenous antibiotics will be offered, but not necessarily so for if they're having a routine caesarean. If they've had a labour, then and have resulted in having an emergency caesarean, then hopefully they've had their intravenous antibiotics as part of their labour. But I forgot what the part of that question was actually. Sorry. There was something else I wanted to say.
Well, whilst you're gathering your thoughts, let me just comment on the cesarean section. So all women who are having cesarean section will have aphylactic antibiotics administered. That's usually broad spectrum. And women who have Group B Strep colonization, who are having a planned or elective cesarean section, don't need antibiotics to protect them from that Group B Strep specifically, unless they've gone into labor. Labor here defined as a cervix opening by more than 4 centimeters, or their waters are broken for more than 4 hours. Under those circumstances, what you don't want to do is to offer them penicillin and then defer the cesarean by the 4 hours that you mentioned.
I think what I wanted to pick up on was around the induction of labour. So it wouldn't necessarily be a matter because they're Group B Strep positive, they would need an end of labour. Induction of labour occurs for various reasons. So for instance, if they go past their due date and no signs of delivering, then we would offer an induction. But the example where they might need an induction, perhaps a little bit earlier than that, is if their waters go and they don't go into labour, then we would offer in labour. But certainly just because they've got Group B Strep wouldn't mean that they have to have a caesarean section, so vaginal birth is still an option.
And so if a woman has had GBS in a previous pregnancy, should antibiotics be given during labour for subsequent births?
It's not a matter that they have to have it. We're talking about being positive for Group B Strep in a previous pregnancy.
Yes, and also
so it wouldn't have to be that they have to have it in the current. They may want want it, and they can discuss that with their trust and have it, routinely. Or alternatively, depending, because they might want options for place of birth, they may choose to have a Group B Strep testing at around 35, 37 weeks to see if it's likely to be prevalent at the time of delivery. And if it's come back negative and if it's not been picked up earlier on in the pregnancy, then they wouldn't need to have antibiotics.
And if they have had a baby who has had a GBS infection in a previous pregnancy, what happens the next time around? What's the
Then they should automatically be offered the antibiotics, IV antibiotics in labour in perpetuity for every subsequent child.
And can antibiotics in labour cause any harm? Is there any?
Potentially could, even penicillin. The thing we're worried about most with penicillin is allergy, and obviously that depends on how severe the allergy we're talking about is. If it's mild allergy, and they can give you a reliable history of either receiving penicillin or penicillin-based products without major problems, there's no reason why they wouldn't have it, or have cephalosporin, for example. The real frightening situation is anaphylactic reaction. Thankfully, it's so rare. We're talking 1 in 5 or 6 million, something like that. So it's exceedingly rare. Exposure of newborns to antibiotic of whatever make is an issue, not just in the sense of altering the flora, but also in the sense of how that baby's immune system is educated, and it's a whole new arena of study recently. The good news around that is the point that Jim made earlier about penicillin being very narrow spectrum. In fact, modern medicine, it kills probably just 3 organisms. Group B Strep is one of them, syphilis is the other, and then listeria. Outside of those 3 organisms, it's fairly ineffective against other agents. If the opportunity exists and the woman does not have sensitivities, that remains the drug of choice.
Okay. And you said narrow spectrum. What does that mean?
Narrow spectrum means that it kills a very small number of bacterial species or subtypes, and does not affect, other bacteria species or subspecies. So what that means is you don't decimate the balance, the logical balance of bacteria in body niches like the lower bowel, the vagina, and these other places. Because under those circumstances, you don't run the risk of developing, resistant organisms.
And we've touched on it a little bit, but how would a baby be monitored after birth?
So all babies, once they're born, will be, checked over by midwife, and we'll also have some observations which include temperature, heart rate, and checking the respirations on the baby's breathing. It gets a little bit complicated here. So what we would hope is that the woman's had the antibiotics in labour, at least 4 hours worth of antibiotics, in which case, and if the baby's fine, there's no other risk factors, then actually, that's all we would do, and obviously, ongoing, just check the baby's okay. If there are some risk factors, then we would be observing the baby more frequently to begin with, and then space out the observations for 12 hours. So that would require mum staying in hospital with the baby. And then depending on what we're finding with that, and maybe things that have happened during labour, for instance, if the baby was born early, or if the water's been gone for a long period of time, if mum had a temperature during labour, there may be some indications to actually, in addition to the observations, baby may require antibiotics. But the key thing is for us to sort of be vigilant, and what we're looking for are the signs that the baby's developing, or hopefully not developing Group B Strep infection.
And so if someone is at home and they have concerns about some of those signs, would you recommend, say, get on the phone to the wife, go to the doctors?
Well, we'll certainly get in touch with a health professional. I mean, if you've got a contact number for your midwife and you can get hold of her straight away, then yes. But if you get through to an answer phone, because obviously they could be busy, then the hospital really, because actually this could potentially be a baby that's not very well, and babies can deteriorate very quickly, and we can get babies checked over. We'd prefer to see a baby that's, maybe just a bit sleepy and just maybe needs more feeding, rather than, leave it and the baby could be developing an infection.
And Jane, Group B Strep Support supports lots of women and families. What are some of the questions that you get most often asked by members of the public?
Well, a number of the questions have been answered already. But I mean, I think one of the key questions we get asked by women is, I want to be tested. How do I do that? And although there are, as Philippa was describing, there's a very discrete group of women where they may be offered the opportunity of testing within the NHS. Normally, they're not. So we list on our website organisations that we know use the right test. So women, if they want to test outside of the NHS, there are reputable organisations where they can purchase a home testing pack for I think it's just over it's about £30, and they can take the samples themselves, send them off. And then in the laboratory they're processed using an enrichment process that really helps the growth of Group B Strep. And that test is the method that's described by the RCOG in their latest guideline. So those organisations listed on our website all offer that test methodology. We get very concerned that if women are going to test themselves, that we make sure that they use a reputable supplier. So I think that's probably the biggest question that we get asked more than anything. Another one is, which Jim and Philippa have both answered, is, I've been told I carry Group B Strep, what do I do next? Well, clearly talk to your midwife, talk to your doctor. Would be happily talk to us, but we'll say talk to your doctor and talk to your midwife as well. And also get informed about Group B Strep. A year and a half ago, the RCOG and we worked together to develop a joint patient information leaflet, and that is the key information about that women and their partners are likely to know about Group B Strep. So that's a really good starting point. The other questions were asked about being allergic to penicillin. What do I do? Well, there are alternatives. Ideally, not clindamycin and erythromycin. Absolutely. If you're going to use an alternative, let's use one that's going to work. Unless you've got susceptibility testing, which so often there isn't. We're also asked about what do I do? I think my baby has signs of Group B Strep infection, and we go, do not pass go, do not collect $100, go straight to your midwife or to your maternity unit, so that the baby can be seen and then the right course of action can be taken. Because so often it can't be done on the phone. The baby.
Well, just to sort of reiterate also what I said earlier is that, sometimes women think, oh, the midwife's coming today, I'll wait. But actually, sometimes the midwife can be delayed, and it could be a long wait. And just take prompt action is really important. And mother's instinct is usually a good judge, so you should be listening to the mums.
So, Philippa, just out of interest, those women that had Group B Strep in their previous pregnancy, and then are wondering what they want to do this time, and you gave the example of the options that are available to them, including a retest. And Jane did comment that they rarely get that retesting, which is also my experience. My question is, how is that retesting done? the staff in your hospital just take a higher as well as they normally would do?
Yeah. Well, in fact, when Jane was answering the question about where they can get tests, some hospitals will offer a test, and I think it's really important that enrich testing, and it's not a hypergenous loss. So some trusts are doing what I would say the correct test at 35 to 37 weeks. I know my hospital does, but I think what's key is to sort of check what test is being done, and hopefully be armed with the information and say this is the test I need, and if in doubt, then try and get the right one.
I think many hospitals don't have reached DCM and reached culture. So there's no point us pretending as though we've now retested them, and if the test is negative, then they don't have it.
No, absolutely.
I think that's positively misleading.
Yeah, because the standard test will miss between 40 and 50% of women who are carrying it.
That's on a good day.
And I think one of the things that we've seen is that although there are a small number of hospitals that are offering the Group B Strep specific ECN test late in pregnancy to that small group of women, actually what a lot of hospitals seem to have done in adopting the latest RCOG guidance is to go, well, we'll just offer all those women IV antibiotics regardless without testing, which is a real shame because only about half of those women are going to be carrying Group B Strep. So, and that, as you were saying before, immediately narrows some of the choices. And of course, it means we're using antibiotics when actually half of those women won't be carrying Group B Strep. So let's use them where they're going to do some good, but not where they're not.
So you'd be encouraging healthcare professionals and women to be asking the hospitals what sort of tests. Absolutely, and everything on the RCOG website, GBSS, and going with that information.
Absolutely.
Okay. And Jane, it's probably a question you get asked a lot. Why doesn't the UK screen?
So yes, we do get asked a lot. And how long have you got? No. In a nutshell, the National Screening Committee is the body that recommends screening programs in the UK, and they are not persuaded by the evidence that screening would do more good than harm. Despite, we think that's fundamentally flawed, and the evidence from other countries where they have introduced screening, their rates have gone down substantially. In the UK, our rate since before our risk-based strategy was introduced has gone up by 19%. So other countries are going down, ours is going up, not great. But the good news around that is that earlier this year, the research arm of the NHS, the National Institute for Health Research, has funded a large-scale trial which is going to compare the current risk-based prevention strategy with screening strategies. So half of those screening strategies are going to be testing women at 35 to 37 weeks with that enriched culture medium test, and the other half of that screening arm are going to be testing women in labour, and then for each of those where Group B Strep is identified, then offering mums the IV antibiotics in labour. And that trial is huge. It's going to be 80 hospitals throughout England, Wales and Scotland, 320,000 women. Unfortunately, because it's so large, it won't report until the end of 2022, but that should give really good evidence about what is best for the UK. Can't wait.
Jane, there's a slight inconsistency in what the NICE guidance currently is in terms of how we operate the risk-based approach. Focusing on prolonged rupture of membranes, for example, if you're using a risk-based approach, if your membranes are ruptured in excess of 18 or 24 hours, wherever you set the threshold, that woman is eligible for antibiotic administration during labor. The current NICE guidance says don't give antibiotics unless they're on temperature in labor, even if the membranes have ruptured for a long time. So it makes me wonder, that's actually a degradation of the risk-based approach, which we don't think is great in the first place. But then we have guidance that is actually weakening it further. My question is, and I don't know this for sure, I don't know if you know what that NIH research, how they define risk-based approach and what they want to do with women with prolonged rupture of membranes.
Yeah, I think women with prolonged rupture of membranes is really difficult because in the RCOG guidelines, it's listed as a risk factor for early onset group B strep infection, but it's not listed as a trigger for the offer of IAP, of the IV antibiotics. There is some conflict with the NICE guidelines. I'm hoping that with the update to the NICE neonatal infection guideline, that maybe there'll be some pulling into line, and certainly identifying and tracking the information from different risk factors. Because it's a cluster randomized trial, that's not going to be possible for every individual woman, but they are going to be doing a sample, so that hopefully that could be looked at and get the really good evidence for it. But you do kind of think if a woman's waters have gone for a long time, then there is inherently a greater risk of infection to the baby.
Totally. I have to anecdotally, the number of times we have had babies that succumbed to early onset group B strep disease, it has been on the back of rupture of membranes where antibiotics have not been administered. So we follow others, but the outcome is what it is.
I'm with you.
So we've only got a few minutes left now, time to quickly. We've just got some pre-submitted questions, which I think have mostly been covered through other things that we've been talking about here. There was just one, Philippa, that you might be able to answer. Someone said that their first baby had a GBS infection and they're pregnant again. They're feeling very worried. Have you got any tips or suggestions where they can go for support or what they can do?
They're pregnant again.
They are.
So they should have a midwife. So first line is speak to the midwife, talk about their concerns. Have they got all the information about what happened the previous time? They may, their midwife may help them to get that information, whether it's seeing somebody else, and then putting a plan in place to support her through this pregnancy. Everyone's knowledge about group B strep is very different. So if that person doesn't feel that they're getting the support that they really need, then, ideally somebody else in the trust. So they may be under the care of an obstetrician who can help, maybe have contacts with a neonatal team that looked after their previous baby. A senior midwife, as most hospitals have a senior midwifery team that will support women. And then, of course, there's Group B Strep Support group. So, but it'd be good if it was ideally the hospital that she was receiving her care from.
Yeah, and I think also make sure that they've got access to the leaflet that the college and we wrote together, because this is absolutely following the latest RCOG guidelines. So this is actually what should be happening in hospitals. And remember that because she's previously had a baby who had a Group B strep infection, she'll be offered the antibiotics in labour this time around, and they really are highly effective. They are fabulous. They do what antibiotics should do. They reduce the risk massively.
And so we should be seeing these in waiting rooms and everywhere.
I can confirm that in most maternity units waiting rooms, including mine.
Excellent.
And a lot of the requests you get for where to get tested properly for group B strep, including the ECM that we're talking about, actually come from a lot of my patients too.
Yeah. And you know, it's recommended, the RCOG in their latest plan on Group B Strep recommended that every pregnant woman should be provided with an information leaflet about Group B Strep. And, you know, why wouldn't you?
Yes.
So we have one. Let's make sure it's being used. And if women know that that leaflet is available, because they can download it from the RCOG's website, or they can download it from the website. And it's also available in some of the pregnancy type apps as well. So that should give you good information about Group B Strep.
We'll include all the links to those various information resources and guidelines that we've mentioned. One question here that's just come through: how long has the offer of antibiotics during subsequent pregnancies after GBS detection in previous pregnancies been in place?
That was a new recommendation in the September 2017 guideline. But it's always been that if one previously had a baby with Group B Strep infection, then IV antibiotics in every subsequent pregnancy. But the recommendation that if carried is detected in a previous pregnancy, then the offer of either antibiotics or testing, that was new September 17.
And Philippa and Austin, do you have any messages for healthcare professionals about GBS?
If you don't know about it, then learn. There's lots of, actually, when I first became a consultant midwife, because a lot of the questions were being directed in, you know, my directions to help women support their choices in their pregnancy. I actually went to the Group B Strep Support website. There's lots of information on there now. You know, there's also additional information on the RCOG website as well. Yes, you know, seek out information, and maybe, you know, I know different trusts do different ways of learning, you know, have journal clubs and that kind of thing, that if they, one midwife finds out about it, maybe share the information with her colleagues.
And Austin?
Well, my thing is to re-emphasize the message around sampling. People almost default to high vaginal swab. It is not high vaginal swab. It's a low vaginal swab and a perianal or a rectal swab. Using the same swab, boom into a transport medium, get it to the lab as quickly as you can. And if your trust does not have enriched culture medium, get them to get one, because that's to comply with national guidance. Otherwise, you'll be positively misleading women that they're Group B Strep negative, when in actual fact your yield is less than 30% of what it should be.
Well, thank you all so much for joining us tonight, and thank you all for taking part. We'll include all the links to the various resources that we mentioned, and do stay in touch with the RCOG, and also go to GBSS for more information. Thank you.